This is a big topic, and so I wanted to introduce to everybody Kidney Cancer 101. So these are kind of important things and themes that I wanted to kind of set the stage for today. So these are my disclosures. So I wanted to introduce the stats that we have for kidney cancer in the US. And so these are widely available. If you go to the KCA website, they have these. I want to discuss kidney cancer. We're often discussing renal cell carcinoma. And so renal cell carcinoma is by far the most common type of kidney tumor. And among those, the majority of what we're going to be discussing during my talk is going to be focused on clear cell kidney cancer, which is 75% of patients. We have entire sections of today's program that are going to be discussing the rarer variants of kidney cancer, which are a huge focus of our research at MD Anderson. We're going to discuss quickly staging, and I'm going to walk you through the history of therapy development. As Dr. Leibovich just gracefully discussed, very few treatments were available 20 years ago. We have come a tremendous distance in a relatively short period of time. And then I'm going to introduce immune system and immunotherapy, which is going to then build with Dr. Tanir's talk later this afternoon. So let's start. So every year in the United States, there's around 80,000 patients diagnosed with cancer of the kidney or the renal pelvis. You can see that it's more common in men as compared to women. It's always a little tricky because we lump the renal pelvis tumors with these. These are actually in the family of bladder cancer as compared to kidney cancer. And there's somewhere between 8,000 and 10,000 of these a year. So about 70,000 cases of kidney cancer. When you look at staging, it's a little small, but I'll just walk you through. 2/3 are diagnosed localized. This just means that it's in the kidney itself. When you look at regional, this means that it is spread to nearby lymph nodes. And when you look at distant or metastatic, this means that the cancer has spread to other organs and has or spread to lymph nodes that are outside of the abdomen. When you look at the age, so this, we're going to be showing a lot of graphs today, and I think it's we have to explain what these graphs are. So this is a bar graph looking at age, and the peak of it you can see is right here, 65 to 74 years of age. But we have patients that are pediatric patients, less than 20, which are over here. And we have patients that are more advanced age, more than 84. So the average age is 65. When you look across different ethnicities and races, you can see it doesn't spare anyone. Potentially a little higher in Native American, Alaskan Native, but it impacts all different races, creeds, genders. When you go into staging of kidney cancer, this is a very nice diagram that's available on cancer.gov, but stage 1 means that the tumor is just in the kidney and is less than 7 centimeters. And it's not trying to exit out of the kidney into the surrounding fat, going into this area, which is called the renal pelvis. This is where urine begins to collect, and certainly not going into other organs or into blood vessels. Stage 2, still confined to the kidney, but larger, now 7 centimeters or bigger. These tumors are often massive when they're discovered, and these can grow at times over the span of many years, but some of these can grow extremely rapidly. Stage 3, again, is growing either into fat, growing into blood vessel, growing into this collecting system of the kidney, or having traveled to nearby lymph nodes. Stage 4 means it's either traveled directly into the adrenal gland, which sits on top, or traveled to distant organs or lymph nodes. So prior to 1985, so 1985 was a great year for me. So I was 4. The Chicago Bears were the best football team in the world. And it's been since then, since the Bears have been that good. But this was the first year that we actually had a therapy that showed promise in kidney cancer. Chemotherapy had been tried in a variety of ways and did next to nothing. Radiation therapy had been tried, and at the time when with how radiation was delivered was proven to be ineffective. So we've literally had surgery and that was it. So in 1985, there's a development of interleukin-2. This is called cytokine therapy, and we're not going to spend a tremendous amount of time here, but these are chemicals that your body produces when you're sick. When you're coming down with a cold or flu, your body produces these chemicals that give you fevers, help you fight against infection. So this is basically giving you a severe flu. And what we showed with this, and what here, you're going to see a number of these today. These are called Kaplan-Meier curves. Kaplan-Meier curves, just walking you through, 100% of patients are alive, 0, no patients are alive. And so if you were to do a graph of survival of humans, if you went out to 140, unless you're in the biblical times, you're not going to see any people alive at 140. So here, what this breaks down is CR stands for complete response. So if your cancer completely disappeared on this therapy, this is measured in years down here. Patients were cured. These were durable, but this cured 5 to 7% of patients. Everybody else suffered side effects and didn't have significant benefit. PR or partial remissions, this means the cancer somewhat shrunk. Some patients did well in the long term, and then no response down here. You can see how patients did. So in the same era, they did a study with interferon. Interferon was a milder version, was more acceptable to patients who were older and had health conditions. High-dose interleukin-2 was a very deadly treatment initially, especially if patients were older and had health-related problems. This treatment did not work well. It really had a benefit of about 3%. I mean, imagine taking a medicine that made you feel like you had the flu that didn't provide any major benefit, and that's what we had. But during this era, this is the Memorial Sloan Kettering risk scoring, and what they did was they were able to break it down. So patients that had elevated calcium, had lower red blood cells, LDH, which is a lab test that was elevated, had to get started on treatment within a year of their diagnosis, or they had an impaired activity level. If they had any of those, they would get a point for each of those. You added those up, and if they had 0 points, patients on average would live about 3 years. There were patients that did well in the long term. If you had 1 or 2 points, the survival was around 17 months. And if you had 3 or more, your survival on average was 6 months. So that's where we're starting. So let's talk about clear cell kidney cancer. So the problem with clear cell kidney cancer is you lose the function of a protein called VHL. When VHL quits working, the oxygen sensor that we have in our cell called HIF starts to build up. This is a sensor that we use to help ourselves heal, grow blood vessels, but kidney cancer clear cell takes advantage of this. And as HIF begins to accumulate, it makes its way into the nucleus where all your DNA is stored, and it sticks onto the DNA in the nucleus. And when this happens, these tumors start squirting out into their environment growth factors. The most famous one is VEGF. VEGF stands for vascular, which is a blood vessel, endothelial, which are these tiny cells that line blood vessels, and growth factor is basically another word for saying fertilizer. And on all these cells, there's receptors that are looking for this, and when they interact, it causes these cells to sprout more blood vessels. And so you're constantly feeding the tumor more nutrients, more blood. So our early successes, 2005 to 2015, were developing therapies that block this. And what you can see is we could block VEGF with an antibody, and then we developed pill-based therapies that were capable of blocking these receptors from sprouting. So some of the early ones were sunitinib, pazopanib, axitinib, sorafenib. So we started trying to see, are patients doing better with this era where we have these new drugs? So we have a very large group of hospitals that compile patients together called the IMDC. And this big compilation was able to spit out now a scoring system that was very similar to what I showed you before. Now we've added in elevated platelet count, neutrophil count. These are very easy to calculate. And now we're having patients on average live longer. So now patients with the favorable risk with 0 points are living 44 months. We've improved things for about a year. Intermediate, 27 months. So we again improved things by about 10 months. Our poorest patients were lagging behind about 9 months. And this was back in 2009 when this was presented. This is an example of an important study at that time called COMPARES, which looked at, did you start treatment for metastatic disease with sunitinib or pazopanib? And the average patient lived for just over 2 years. So now I'm going to introduce you to the immune system. So the immune system, going all the way back to flies, you have neutrophils. These are your early responders. This is what changes your mucus bad colors when you're dealing with colds and flus. You have your macrophages that eat up dead cells, and you have your dendritic cells that I think about as like the puppy dogs of the immune system. They're constantly picking up debris that we call antigens, and they're taking them to show off in lymph nodes to T cells. We have NK cells that Dr. Chenier will discuss more. These are very interesting and a big area of research that we have going on at MD Anderson. And then the adaptive immune system is what we see in vertebrate animals and mammals. We have B cells. These are your antibody factories. They produce plasma cells that produce all of your antibodies. And you have your T cells that are your smart killers. Now, the immune system has to be very delicately balanced. This is crucial because too much use, you get into trouble. So tuberculosis was called consumption. And the reason why is you would have infection where you would devote all of your energy stores to try to fight this infection you could not get rid of. You can have inflammatory conditions like rheumatoid arthritis and lupus. And cancer can be caused by too much inflammation. We see this in an autoimmune condition called ulcerative colitis, where we see patients develop high rates of rectal cancer, colon cancer. So underactive is equally challenged. You can die from infection. You can die from not being able to heal wounds, and you can develop cancer as well. So that has to be delicately balanced. So how do we do this? So there is constant communication that's going on between cells, tissues, organs, talking back and forth to the immune system. Subsignals stimulate the immune system and some suppress. Some immune cells attack cancers, and then cancer will cause some to protect it. And so it's this delicate balance that's going on. What I'm showing here is very, very rudimentary, but basically for macrophages, green can be anti-cancer, red can be pro-cancer, and same thing with T cells. You can have anti-cancer and you can have potentially pro-cancer, and getting this balance together is important. Cells are like homes. You have to take your trash out once a week, get it picked up. If you're not taking your trash out, the homes explode. There's entire television shows about this. And so cells are constantly trying to show off what's going on inside. So pieces of components of proteins are constantly broken down within cells. And this is an example of a cell that's infected with a virus. As the virus particles are broken down, these cells are showing off what they have with something called MHC. When MHC is showing antigen, or what it found out, a T cell has a chance to come and a chance to kill the cell. So these tumor environments where cancers is very complex. And I drew a lot of these red cells because we have a lot of cells that are defending the cancer. So how can we get good immune cells to tumor? Well, over time, you do have tumor cells dying in a variety of ways. And as they're dying, they release antigens that, again, can be picked up by the puppy dogs of the immune system, the dendritic cells. And once it's picked up on MHC, it can rush into lymph nodes where you're having T cells. Within T cells, if you have a perfect match receptor, you have a chance for a T cell to turn on. This happens with this interaction, and this is not important to memorize, but green here is good. So CD28 is good for activating a resting T cell, turn it into an effector. Red is bad. This is CTLA4. When CTLA4 comes up, these T cells will not turn on, they'll remain resting. So what happens with cancer? So Dr. Jim Allison, who you'll hear more about today with Dr. Tanir's talk, helped develop a drug that can block CTLA4, making it easier from a resting T cell to become an effector T cell. And then over the course of several days, develop millions of these T cells to travel, but also have the ability to generate memory. And this is really the trick behind immunotherapy. If you can make your immune system go attack cancer and then remember cancer, then we're hitting the home run that we're after. So tumor cells are tricky. They use other programs, and there's a lot of these to keep T cells from attacking. One of the famous ones is called PD-1-PDL1 interaction. So T cells put this up to stop themselves. When a T cell has PD-1 on its surface, it's ready to attack, but it's tired, and it wants a reason not to attack. When this interacts, it causes this T cell to hibernate or die and not attack. When we block this with drugs such as pembrolizumab or Keytruda, nivolumab or Opdivo, we're allowing this T cell, when it's ready to attack, to have that opportunity, and then have a chance to kill the cancer. So we're going to briefly come back to the slide that I showed earlier with targeted therapy as this has continued to evolve. Again, the problem is the loss of VHL. You have HIF buildup going to the brain or the DNA portion of the cell. They squirt out too much VEGF, which are for the blood vessels and the cells that line blood vessels. And we have come a long way in blocking some other important pathways too that can cause these cancer cells to grow or cause immune cells in their environment to survive. And we have now medicines that are commonly used include axitinib, cabozantinib, lenvatinib, tivozanib. All of these block this blood vessel pathway. Some of them block other important pathways. And the latest development is a drug called belzutifan, which targets HIF itself. We have found that combining these drugs together with immunotherapy can enhance the chances that patients respond. And we've gone from an era when we use a pill by itself where about 30% of patients will have their cancer shrink to upwards of 70% of patients will have their cancer shrink with therapy. So when we need to get the cancer to respond quickly, these can be good strategies. We also use two immune drugs together that Dr. Tanir will discuss more during his talk. So this is where we come, and this was highlighted by Dr. Leibovich. We've come a long way. You can see until 1992, we had nothing. We now have high-dose IL-2. 2005, you see all of these orange ones. These are the targeted therapies targeting the blood vessel pathways largely. 2015, we suddenly have new immunotherapy emerge. In green, we have the combination of two immunotherapies, which is now a standard frontline. In red are the pill immunotherapies that are now standard frontline. And our most recent for immunotherapy is the approval of using immunotherapy trying to prevent the return of cancer. And this is with pembrolizumab, and this is in itself a rather complicated topic. But patients are now doing much better than what I showed before. And Dr. Tanir will highlight this to some, but we now have 8.5 years of follow-up after patients receive Nivo-Ipi. And about a quarter of patients have never had the cancer grow and have been off of therapy for an extremely long period of time, and we hope are in fact cured. And so we are making major inroads now. I think many patients are making it well beyond 5 years, and our goal is enhancing the opportunity to cure more patients with the goal of trying to get patients off of therapy back to normalcy. So in conclusion, we have an explosion of treatment options that have emerged. We have come a long way, but we still have a long way to go, and partnership is crucial. We have a very busy meeting today where we're going to be discussing surgery with Dr. Mateen, radiation with Dr. Tang, and ablation with Dr. Sheth, talking about holistic care with integrative medicine with Dr. Morse, the importance of diet with Dr. Daniel McDougall, highlight immunotherapy with Dr. Chenier, highlights non-clear cell or variant histology with Dr. Pavlos Masal, discuss side effect management with Zita Lim, who has been Dr. Chenier's right hand for a long time in clinic. Patient and caregivers are our partners, and thank you to all who attended today. A special thank you to our speakers and their caregivers with Mike McGee, Katie Coleman, and Bill Hoffman. With that, I want to end. So what you'll see in these final pictures, so this is the legend that we've been discussing today, Dr. Chris Wood. He was a very dear friend, mentor. I'm the person that's out of place here. This is a surgical conference. So Dr. Wood basically brought me along to give me opportunities, and I got involved with the KCA because of him. Here is a walk in his honor that we did last year. You'll see smiling in front, MJ Musa, who's up in the front, a fantastic postdoc. This is our big bone metastases lab that I work with. And so we are committed every day to try to continue this battle against kidney cancer. And with that, I thank you, and we're going to move on to the next talk.